We share well, don't we? We tag team. We do. We've had a lot of fun. So my assignment for today is I have the honor and the privilege of introducing our first speaker. And I was excited about this because I hadn't met him until about 30 minutes ago. And I've heard everybody else speak before, so I said, I'm going to have to do a little research. And I'm a little bit of a geek. I like to research neuroendocrine cancer. Dr. Dawes is a native of Santa Barbara, California. He got his BA from Berkeley in molecular cell biology and immunology. Did I say that right? I'm on a roll. Medical degree from Emory, came south. Fellowship at Vanderbilt in hematology and oncology. Went back to California for his residency. But we're now delighted that he is back in Tennessee, and he is a medical oncologist at Vanderbilt Ingram. He is pursuing his master's in science and clinical investigation, which I'm not sure what that means, but it sounds good. And I was delighted to learn that he has presented at several of the national meetings of the ASCO, and his list of publications was very intimidating in context, but the titles sounded interesting. So I probably am going to try to read a few of those with my dictionary. But I think with all of these impressive credentials, I think the reason I am most excited to introduce him to our group today to present an overview of NETs and to get us started were all of the wonderful, positive comments and compliments I have heard about Dr. Dawes as I was helping to register individuals and answer questions for this convention. So you come with a great reputation to me, and I look forward to hearing what you have to say today and getting to know you better. Dr. Sasha Dawes. Thank you. You know how to work this? Oh, good.
All right, no problem. Thank you so much for such a kind introduction. It's really a privilege to be here. Thanks to Bob and Marianne for having me. And it's wonderful to look out and see so many familiar faces. As mentioned, I am a GI medical oncologist at Vanderbilt Ingram. I do focus on patients with neuroendocrine tumors, and my passion is to bring new drugs and treatments for folks like you. And so I've been tasked today with giving an overview of neuroendocrine tumors. I think we're truly lucky to have folks like Dr. Liu and Dr. Anthony, and I hope to lay the scenery for some of the discussion to follow. Okay, sorry. All right, so these are my disclosures. This is a brief roadmap for the talk. So what I hope to actually do is go over some background and lingo so as to set the stage for the discussion today. Talk about some key differences between neuroendocrine tumors and other types of cancers. Talk about important questions to ask when you or a loved one gets a diagnosis. What's important and why is it important? Then I wanted to focus a little bit on systemic treatments. That's an area that I focus on in my practice. And finally close with what I think are some areas of need and take-home points to pass on from today's discussion. So I think it's impossible to talk about neuroendocrine tumors without talking a little bit about the origins. And so Shakespeare said, "What's in a name?" And I think everything in the context of neuroendocrine tumors. The gentleman who's pictured here was a German pathologist whose name was Siegfried Oberndorfer. And in 1907, he was the first individual to identify a neuroendocrine tumor from a pathology report of a resected patient. And he actually called the neuroendocrine tumor carcinoide because he didn't know what else to call it. And in German, carcinoide means carcinoma-like. He thought that these were benign tumors, but they behaved like cancer under the microscope. And so since the inception of neuroendocrine tumors, there's always been some confusion about how these tumors behave and what they are capable of doing. So a little bit about background. I don't want to focus on the text, but I'll try to highlight some of the key points from each slide. So we know that neuroendocrine tumors arise from any endocrine cell in the body. 70% of neuroendocrine tumors arise from the gastrointestinal tract or the pancreas. About 20 to 25% are from the lungs, and the remaining 5% are from rare organs such as the adrenal glands, nerve sheaths, and other areas as well. So we talk about neuroendocrine tumors being zebras and rare tumors, but they're actually not that rare. More than 170,000 patients in the United States carry a diagnosis of neuroendocrine tumors. And in fact, over the last 30 years, the incidence or new cases of neuroendocrine tumors has gone up by about sixfold. And that there is something there beyond just better imaging that we have, that we need to figure out why the incidence of this disease is increasing. I do like that picture on the right because it shows us another way to think about neuroendocrine tumors and the way we categorize them. So neuroendocrine tumors are not just categorized by the organ in which they started, but rather the embryology of that organ. So some of the terms that you guys might hear are, for example, a foregut neuroendocrine tumor, and that refers to things like a pancreas neuroendocrine tumor, a lung neuroendocrine tumor. Midgut neuroendocrine tumors are those that arise most commonly from the small bowel, and hindgut neuroendocrine tumors are those from the distal bowel and rectum. So, the lingo. I know many of you are very well versed in the lingo of neuroendocrine tumors, but I think it's worth it to go over these things. I know sometimes it can seem like the Da Vinci Code and decoding what these things mean. However, I think we really have to identify what these tumors are and what these terms mean before we can actually talk about how to treat them. So, a carcinoid tumor, as you guys all know, is a neuroendocrine tumor that arises typically in the small bowel. Carcinoid syndrome is classically characterized by serotonin overproduction, and it's defined by things like flushing, diarrhea, and shortness of breath, and it arises most commonly in the setting of a hormone, serotonin, that's produced by a carcinoid tumor. Resectability, that means is a tumor surgically removable? OMA, typically that refers to a pancreas neuroendocrine tumor that produces a specific hormone. So for example, a tumor that produces insulin is called an insulinoma, one that produces a hormone called VIP is called a VIPoma, and the like. Ki67, this is a really important protein that we'll talk about sort of throughout the course of this talk. And what this is it is a surrogate for how aggressive or how active a cell is. Ki67 is usually referred to as a percentage, and we'll talk about how that factors into grade. Similarly, mitoses. Mitoses is another marker of how active a cell is. So for example, a neuroendocrine tumor with higher mitoses, we tend to think of more aggressive, and one with lower mitoses, we tend to think of less aggressive. As mentioned, grade. So that is perhaps the most important definitive characteristic about a neuroendocrine tumor is the grade. And the grade is a composite score of several different entities. So as mentioned, the Ki67, the mitosis, and a component that I'll get to in a second called differentiation. And what that refers to is how a tumor looks under the microscope and how similar it looks to the organ in which it started. So I spoke a little bit about differentiation. We'll next talk about neuroendocrine carcinomas. So we know that sort of the mascot for neuroendocrine tumors and for all of you is a zebra. But I think the thing about these zebras is that they come in various flavors. And a neuroendocrine carcinoma is unfortunately the most aggressive variant of neuroendocrine tumors. These are tumors that are defined by incredibly high Ki67s, more than 20%, but usually in the order of 80, 90%, a number of mitoses, and these tend to grow very quickly. 5-HIA, Dr. Anthony will touch on this in great detail, but this is a breakdown product of serotonin. So this is an actual value that you can measure in the bloodstream or in the urine that can tell you how active a small bowel neuroendocrine tumor is and if it's producing the hormones that we think it may be. Response rate. So you guys will hear response rate a lot, but honestly, response rate is a very specific term, and it was defined in the context of clinical trials. So for for a tumor to qualify as a response in a clinical trial, it actually has to shrink by 30%. So just important to think in mind when you guys are looking at new therapies and response rate is mentioned, that specifically refers to tumors shrinking by overall 30% to qualify in that category. And progression-free survival is another really important term. We'll go over a number of graphs, and what that really refers to is how long it takes for a tumor to progress on a therapy. So the longer progression-free survival on a therapy, the better. Ideally, we'd love to see an infinite progression-free survival and never see these tumors grow. So before we talk a little bit about some of the important questions and why the answers matter, I think it's really essential to talk about some of the differences between neuroendocrine tumors and other tumors. So neuroendocrine tumors, for whatever reason, due to their disease biology, do like to spread to other organs. However, the prognosis is very, very different from that of other tumors. In the context of other cancers like breast cancer or colon cancer, when it unfortunately escapes out of the organ in which it started, we think about it being incurable or metastatic. The prognosis for a well-differentiated neuroendocrine tumor that has metastasized or grown out of the organ at where it started is incredibly different from that of a metastatic tumor elsewhere. And that's a really, really important point that I hope to harp on for the rest of this presentation. Grade and differentiation are more important than stage. That's different from other tumors, but really it's the grade and differentiation that are key about the insights about how the tumor is going to behave. Again, sometimes patients with metastatic, well-differentiated, low-grade tumors never need treatment other than observation, and that's very different from other tumors. And the first-line treatment for tumors that express a receptor called somatostatin, which is about 80% of neuroendocrine tumors, can actually just be a monthly injection, octreotide or lanreotide. And so, again, the treatment approach is very different than what we would think from other tumors that may have spread to other organs. The tempo of progression is incredibly important. So treatments in neuroendocrine tumors that slow the tempo of growth can be considered effective even if they do not stop growth completely. And I wanted to point your guys' attention to the images here. This is from a patient of mine who had a small bowel neuroendocrine tumor. And what you can see from the scan, these darker areas here refer to metastases in the liver. So this was 3 months ago, and this is his current scan now. And I know it doesn't look like much difference, but there's actually been a few millimeters of growth in the tumors in the liver. However, this is still a successful treatment because the tempo of growth has been slowed significantly by octreotide, which this patient happens to be on. And so this is still considered a successful treatment in this disease. Hormone production from some of these tumors can be life-threatening, and it's really important to identify them. So we'll talk about things like serotonin, and Dr. Anthony will get into this as well, about causing leaky heart valves or carcinoid heart disease. Some pancreas neuroendocrine tumors can release hormones like gastrin, which cause peptic ulcers that can cause bleeding. Insulin production from pancreas tumors can cause low blood sugar and feeling clammy, and even life-threateningly low blood sugars. These are all important hormones to identify that a tumor may be producing. And finally, even when we're able to take out all of the tumor, neuroendocrine tumors have an odd pattern of occurrence. They can recur much later than other tumors. So in the setting of other cancer, we think about typically 5 years. That's usually the routine period where patients are followed before we can declare them cancer-free. In neuroendocrine tumors, it's a little bit longer because these tumors can occur at a later period of time. So I think perhaps this may be the most important slide in my talk, which is what are some important questions to ask after you or a loved one have been diagnosed or are evaluating other treatment options. So the first question is, where is the primary site of the tumor? And that's an incredibly important question because, as we'll get into in the next slides, the primary site defines what treatments are available. Is the tumor only localized, or has it spread? Does it involve distant lymph nodes or distant organs? Can Dr. Liu take out all your tumor? Yes. You know, what is the grade of the tumor? What is the Ki-67? Is the tumor Yeah.
I'm a little bit ahead of you, but
Yeah.
how do you find out whether your tumor is producing
Yeah, so typically when you're diagnosed, a lot of it's a clinical discussion. So if you have certain things like flushing or diarrhea, typically we actually order a hormone level on that first visit to check if it's producing a hormone. And if you have a pancreas neuroendocrine tumor, we usually check a glucagon level or a gastrin level if there's some symptoms that there may be in peptic ulcer or high blood sugars or things like that.
I just recently went to a Moffitt.
Mm-hmm.
They did nothing. And how do I know all these things?
Yeah, so I think it's important to message your doctor there to talk about that. Hey, I think it's worth it that we think about getting these hormone levels checked, and I think that's how I'd go about it.
I did ask that.
Yeah.
They refused.
Okay.
So I'm very confused.
Yeah, so I think it's something that again, as Bob had mentioned, sort of being an advocate for yourself. And so I think it's worth it to perhaps bring it up again, or even ask why at this point they don't want to check those levels, because there may be a good reason.
Yeah, we have a Q&A.
Okay, not a problem.
At the end of the session, write those questions down and we'll answer as many as we possibly.
Yeah, no problem. So is the tumor a neuroendocrine tumor or a neuroendocrine carcinoma? That actually is a huge influence on what kind of treatments are offered to folks. We talked about the hormones. Are tumors active? And does the tumor express somatostatin? And how do we detect that? And what's the best scan that should be done in order to best stage the tumor? So I'm actually going to start with somatostatin, and the purpose of this image, I think, is to really tout the power of a practice-changing scan. And what I want to point your attention to is the image on the left. And what this shows is the same patient who had a small bowel neuroendocrine tumor, who had a gallium scan, or a gallium dotatate scan, or an octria scan, which is what we used to use. And I think the thing that points out to you or jumps out to you is just the number of tumors that previously were not able to be seen on an octria scan that are seen on a dotatate scan. Now, I will tell you that 80% of neuroendocrine tumors express the receptor somatostatin, still leaving about 20% that do not. So there are instances where your tumor may not light up on a dotatate scan, but in those instances, most likely it does not express that receptor. So you might ask yourself, well, we know there's more tumors. How does that actually change our management? And I'll tell you from a personal experience, it can change our management greatly. These are actually examples of two cases of patients that we've published. The first patient on the top right was a gentleman who had a small bowel neuroendocrine tumor that was resected 4 years ago. His outside oncologist ordered a dotatate scan to see if he had any disease and just to kind of see where things stood. And what we found was actually a lesion that was in the middle of his heart. It was in the septum of his heart, and he was completely asymptomatic from it. How that changed management was we actually had him plugged in with a cardiologist. We've gotten much closer echocardiographic surveillance to make sure that the heart valves are working and the heart is pumping forward. And we've actually started sandostatin on him, and he's doing fantastic. The echocardiograms have not revealed any growth of his tumor, and he's having no symptoms from having that tumor there. This was another patient that I had who actually, again with this neuroendocrine tumor, actually diagnosed with the asymptomatic orbital metastases, or the muscles that move the eye. He was noted to have a neuroendocrine tumor there, and that's depicted here. And fortunately, he wasn't having any symptoms, but how that changed our management was we got an MRI to follow that at a closer interval. And when we saw a little bit of growth, we ended up radiating that tumor so that it wouldn't cause any problems. And again, he's completely symptom-free. So finding tumors in places that we did not expect is a powerful addition and a reason why, if available, a dotatate PET scan is the ideal imaging standard for somatostatin-positive tumors. Again, as with everything in life, there's a cost. So because we can see more things with these dotatate scans, there are certain things that might light up on the scan that aren't neuroendocrine tumors. So I wanted to, I'm sorry, this didn't show well, but what I wanted to point your attention to was this is a picture here of an area on the pancreas, the head of the pancreas, that can light up physiologically because it has the receptor somatostatin. Now that's not a pancreas neuroendocrine tumor, that's just normal, but that can light up on a acetate scan. Classically, what we see are a lot of bone areas that light up. So for example, if folks have bony disease, in terms of from degenerative disease, may have a benign bone tumor that's not neuroendocrine, that can light up. Prostate inflammation can light up. So these are all things just to keep in mind when you are getting and are having discussions with your physicians. So why does primary site matter? Primary site matters, again, because it dictates the amount of treatments that are available. So I wanted to point your guys' attention to first on the left-hand side of the screen. That's a pancreas body neuroendocrine tumor. And what you can see is that there's a number of FDA-approved treatments that are available. The one thing is this treatment right here, capecitabine and temozolomide, is in italics because it has randomized trial data, but it's not FDA approved strictly for that indication. Similarly, you see a small bowel neuroendocrine tumor in the small intestine right here, and you see that the treatments are a little bit different from the pancreas neuroendocrine tumor. And again, I don't have a slide pictured here, but a lung neuroendocrine tumor has a different treatment algorithm for what options may be available. So primary site has a big influence on what treatments are available. So what about the grade? Now I spoke to you guys about low grade and high grade, but as with all things, there's a spectrum. So when we think about low grade tumors, we think typically about grade 1 and grade 2. Again, well differentiated, and I'll show you what these look like under the microscope so that hopefully you can hit home how different these types of tumors look. What's really interesting is I told you that tumors with a higher Ki-67 or higher proliferation capacity are typically poorly differentiated. But there is a caveat as well. There are a subgroup of patients who have tumors that are grade 3 well-differentiated tumors, meaning that under the microscope they look similar to the organ in which that tumor started, but they might have a little bit of a higher growth rate. And those are very different from a poorly differentiated tumor. So this category right here is something that we've probably defined over the last 1.5 to 2 years that didn't exist. So again, how do these things look under the microscope? So this is, I wanted to point your guys' attention to first this Ki-67 here. And this is a spectrum here. So going from A to B to C, the Ki-67 is a protein that stains brown in these slides. And again, it measures sort of activity of tumors. And so what you could look like here is in panel A, this is a low Ki-67 tumor, about less than 2%. And what you can see is there's very little brown on this slide. In the middle, an intermediate grade tumor, and what you can see is there's more brown that's staining. And then finally here is a poorly differentiated neuroendocrine carcinoma, and you guys can see essentially this entire slide is covered in Ki-67 because all of these cells are dividing so rapidly. How about appearance? So this is a well-differentiated small bowel neuroendocrine tumor, and this is actually very normal with how the architecture of the small bowel appears. When you focus here on the slide on the right, it looks nothing like it, almost like a bizarre appearance, and that's the appearance of a poorly differentiated neuroendocrine carcinoma. It looks nothing like the organ in which it started. So what are some of the hormones that neuroendocrine tumors can produce? I won't touch too much on this because there's an entire talk dedicated to this. But again, so serotonin can be overproduced by small intestinal neuroendocrine tumors. Typically, serotonin is broken down into the liver into its byproduct called 5-HIA. However, when folks have metastases in the liver, typically the liver just cannot break it down as effectively. So serotonin can run free in the bloodstream and deposit in different areas. And you might ask yourself, well, why does that matter? Well, serotonin deposition can cause fibrosis, and it can cause leaky heart valves if it deposits in the right heart, which can cause life-threatening heart failure. It can deposit in the gut and cause life-threatening bowel obstructions. And so serotonin is a really important component in folks with tumors that produce serotonin to control. So how do we control serotonin? Well, the most common ways are to actually slow the production of serotonin with your tumor, and that's through monthly injections, octreotide, lanreotide, or surgery. When you actually debulk a tumor or take out part of it, that lowers its capacity to produce serotonin. There is an FDA-approved drug called telotrestat that actually prevents the conversion of serotonin. Serotonin is derived from a natural amino acid called tryptophan. And so if you block that conversion, you can also reduce the serotonin amounts. And this is a very interesting drug that we're looking at, trying to move earlier in lines of treatment to lower serotonin. And finally, there are some dietary restrictions. There's high tryptophan foods that can cause carcinoid syndrome. But again, as you guys can imagine, if a tumor is really active, trying to control things with diet alone is not going to do much. So what about some of the other hormones? Histamine. Histamine is a common hormone that's produced by lung neuroendocrine tumors. It causes symptoms of almost excess allergies. So it can cause things like itching. It can cause things like shortness of breath. It can cause things like wheezing and flushing. We can measure histamine through a urine assay. And the way we usually control histamine is through treating the tumor, or we actually have older antihistamine drugs like cyproheptadine, which is a way of controlling this level. Gastrin. So this image here is just showing a pancreas tumor that produces gastrin. There's a syndrome called Zollinger-Ellison, which is categorized by excess gastrin production from pancreas neuroendocrine tumors or small bowel neuroendocrine tumors, and that can cause ulcers. So how do we manage gastrin excess? 1, we treat the tumor. 2, we use anti-acid medications, so things like omeprazole or things like ranitidine or Zantac to help control some of those symptoms and preventing ulcers from developing. Insulin. So insulin is one of the rarest hormones that's produced. And again, it really happens when a pancreas tumor arises in the beta cells of the pancreas. And that neuroendocrine tumor can cause symptoms of having low blood sugar. So things like feeling clammy or lightheadedness or dizziness. And so how do we manage that? We can manage it by treating the tumor. We can manage it through things like small frequent meals. And we can manage it through drugs that actually prevent insulin secretion. So diazoxide is one of those examples. But typically, if folks have an insulinoma, they are managed with endocrinology because it's a very nuanced tumor that can be challenging to manage. So the role for surgery, Dr. Liu has a talk entirely dedicated to this, but I think the main upshot that I wanted to pass on is that if it can be taken out, that's still the best thing. Sometimes surgery is done even when a tumor cannot be completely removed, and that again is to prevent it from pushing on a critical organ or producing hormones that may cause life-threatening complications. There is one study that I wanted to go over, and this pertains to small bowel neuroendocrine tumor patients. So previously in metastatic small bowel patients, those who had disease that spread outside, we would always take out the primary site because we thought that it would prevent things like bowel obstructions and complications down the road. There's a recent study that was published in JAMA in 2018 that looked at the advantage of LRS. LRS just stands for local regional surgery, whether we should do surgery right up front for these metastatic tumors, or whether we should wait till patients have symptoms to do so. And what you see here is that there was actually no difference in survival between when we did the surgery. And so I think it points to the fact that there are times we have to be thoughtful about when we do surgery in the metastatic setting for neuroendocrine tumor patients. So so the role for liver-directed therapy. I won't get into this too much, but this is again speaking about interventional radiology procedures. So interventional radiology procedures to directing and treating tumors in the liver absolutely has a role. However, typically this role is defined for folks that just have tumors in the liver, or may just have a tumor in the liver that's particularly symptomatic and causing problems like pain or other things, or even liver dysfunction. And the liver is very interesting. Unlike other organs, it actually has two sources of blood supply. It gets it from an artery, and it also gets it from the portal vein, meaning that you can actually choke off the blood supply to a tumor by blocking the artery while still having the vein supply normal liver to make sure that the liver is functioning correctly. Previously, we used to use what we called radioembolization, which was beads that were coated with a radiation particle, most commonly Y90, and that was injected into the arteries that fed the tumors in the liver. We're starting to move a little bit away from Y90 with the advent of more radiation-based therapies like PRT, which I'll touch on, and actually looking at things like bland embolization, which is just putting putting beads in there to block off blood supply, or chemoembolization, a bead that's coated with chemotherapy. And the main purpose of this study is just to show that HAE, which is hepatic arterial embolization, and RE, which is the Y90 radiation-based embolization, had no difference in outcomes at 6 months in controlling. So both modalities are useful, but we are again now moving away from radiation to the liver directly because of some of our other treatments, and we want to make sure that the liver is in good enough shape to give some of these other treatments. So this is now kind of moving to the realm where I mostly live, in treating patients with systemic therapies. So we know that for patients who have somatostatin receptor expression on their tumors, the first-line therapy for metastatic folks or who have hormone production is just a monthly injection, octreotide or lanreotide. And although octreotide and lanreotide were approved for slightly different reasons, octreotide garnered its FDA approval for controlling carcinoid syndrome and lanreotide for slowing growth. We both know that they actually, both of them, slow tumor growth and work very, very similarly. So I just wanted to go over 2 studies, and what I wanted to point your attention to is, so the y-axis is progression-free survival. So remember, that was that term, so how long it took for a tumor to progress on a therapy. So ideally, we want to see all our therapies stay here, meaning 100% of patients are progression-free. But what you can see here is in small bowel neuroendocrine patients who had carcinoid syndrome, this was in about 80 patients who were randomized to octreotide or placebo. At that time, we had nothing better, so that's why a placebo was used. Octreotide slowed tumor growth by about 50%. This study was the study that got lanreotide its FDA approval, called the Clarinet study. And this was in a larger group of patients, but in pancreas and gastrointestinal neuroendocrine patients who actually didn't have carcinoid syndrome. So their tumors were non-functional. And they were randomized to lanreotide or placebo. And again, what you can see is, in terms of slowing progression, lanreotide did so by about 50%. So what about some other options? There is an FDA-approved pill therapy called Afinitor, or Everolimus. And Everolimus is FDA-approved for the treatment of lung neuroendocrine tumor patients, small bowel neuroendocrine tumor patients, and pancreas neuroendocrine tumor patients. And I just wanted to point your guys' attention to this diagram here. The details are not important, other than the fact to mention that Everolimus, or Afinitor, blocks a protein called mTOR. And mTOR is responsible for a lot of things like cell growth, blood vessel growth, and glucose utilization. So by blocking that pathway, we are able to block tumor growth and tumor sustenance. Again, the big thing with this drug is it slows tumor growth, but it doesn't cause a whole lot of shrinkage. So the response rates with this drug are only about 2 to 5%. And that's something that we'll get to in a second. It is a pill, however it does have side effects. Some of the most common things we think about are high blood sugars, it can cause mouth sores, it can cause fatigue, it can cause leg swelling, and these are all things that can be negotiated by dose, but they are important things to remember. So this was the data for Everolimus that got it its FDA approval. So first of all, on the left-hand side, this is in 300 patients who had basically lung or gastrointestinal neuroendocrine tumors. These patients all grew through somatostatin analogs, octreotide or lanreotide, in the last year, and they were randomized to Everolimus or placebo. And what you can see is that the blue line slowed growth of these tumors by 52%. Similarly, this was in about 400 grade 1 or 2 pancreas neuroendocrine tumor patients who'd grown on octreotide or lanreotide, and they were randomized to Everolimus or placebo. And again, Everolimus reduced growth by about 60% compared to placebo. Yeah, no problem. Okay, perfect. Yeah. So these are some of these other pill options. Sunitinib is one that's approved for pancreas neuroendocrine tumor patients, and again, sort of slows growth. There is a pill combination called capecitabine and temozolomide, which is actually showed randomized trial data in pancreas neuroendocrine tumor patients, and this was presented at ASCO. And the combination, beyond slowing tumor growth and prolonging survival, actually shrank tumors by about 30 to 32%, making it one of the most active treatments that we have for pancreas neuroendocrine tumor patients. It is used for other neuroendocrine tumor patients as well. And I wanted to spend a little bit of time on on PRT and then my takeaways. So PRT is kind of the hot new therapy, and what PRT essentially is it's a somatostatin analog, like an octreotide-based peptide that is actually bound to a radiation particle. So it basically is a smart bomb that delivers targeted radiation to the neuroendocrine tumor cells that express somatostatin. The data that made this so exciting and actually got it its FDA approval was the NETTER-1 trial. And Vanderbilt was one of the participating sites in this study. And this basically randomized small bowel neuroendocrine tumor patients who'd progressed on octreotide or lanreotide to a higher dose of octreotide or octreotide regular dose, 30 milligrams in PRT. And what you can see is a profound reduction in progression compared to the high-dose octreotide arm. And survival hasn't even been reached yet in these patients. And beyond that, the quality of life improvement metrics were improved across the board for this treatment. You might mention, well, that trial was in small bowel neuroendocrine tumors. What about data in other disease sites? This was from the Dutch experience in the Netherlands, in Erasmus, where patients with other types of neuroendocrine tumors were treated with PRT, and you can see prolonged survival benefit of this therapy. So it works in other tumor types. The one caveat is that it is not yet FDA approved for lung neuroendocrine tumor patients. We do treat folks, but that's hopefully something that we should be seeing soon. Again, just briefly wanted to mention that neuroendocrine carcinomas are the most aggressive variant of neuroendocrine tumors. What you guys will see from this slide is that regardless of the treatments that we choose, they're not very effective. And platinum-based chemotherapy, although it works in the first line, tumors grow through it. And there's some exciting data that's emerging with immunotherapy in this disease, but it still needs to be well fleshed out because this was based on a small study. So, some areas of need and then my take-home points. So I think we need more tumor shrinking therapies. As you guys saw, we have a lot of therapies that slow tumor growth, but we still don't have that many that can shrink tumors from a systemic perspective. I think we need more effective therapies for our neuroendocrine carcinoma patients. We need to find ways to make immunotherapy effective in that subset of this disease. We need more ways to reduce serotonin better, and we need better ways to screen for things like carcinoid heart disease in patients with carcinoid syndrome, because detecting that early can really make a big difference. So my final slide is my take-home points. So again, grade and differentiation are more important than tumor stage for these tumors. A diagnosis of stage 4 disease with well-differentiated neuroendocrine tumors is not the same as a diagnosis of stage 4 disease for other tumors. A gallium dotatate scan is the most sensitive scan for somatostatin receptor positivity. Octreotide scans are okay, but if possible, a gallium dotatate scan is the gold standard. When all disease can be removed, that is still the best option. The site of the primary tumor dictates what treatments are available. We are fortunately in a time where new therapies and new trials are exploding, and we are coming up with new things, and I'm excited to see what new treatments we can bring in because they are coming. And finally, Bob mentioned this, but being diagnosed with a neuroendocrine tumor is a nuanced diagnosis. And I think whether you make the decision to get treated locally or at a big center, I think it's absolutely essential, and if possible, to be seen at a place, at least initially, that sees a lot of neuroendocrine tumors. You need experts in multiple disciplines. You need experts in nuclear medicine, medical oncology, surgical oncology, radiology, interventional radiology. And you want people to be talking. You want places that have regular tumor boards where every neuroendocrine tumor patient is discussed, because we know that every patient is truly different. And so I think that I can't highlight enough, but the importance of finding a place that sees neuroendocrine tumor patients. And with that, I'll close. Thank you.